Good afternoon, everyone. Magandang hapon. Ako po si Dr. Arthur Desi Roman. I'm one of the board members of the Philippine Society for Microbiology and Infectious Diseases. Thank you for joining us this afternoon. Uh, it's our 50th anniversary, and I'd like to thank all the participants and everyone who has made this virtual convention possible. We have been in the front lines of the fight against COVID-19, but of course, behind us, we've been receiving a lot of support from our friends and even from our pharmaceutical friends from the pharmaceutical company. And so I am opening this first wave of industry-sponsored symposia, and I'd like to thank Biocare for sponsoring this hour's scientific activity. Our session's topic is MOXI-Why, an overview of moxifloxacin use in clinical practice. And uh, I'd like to introduce Mr. Dilip K. Tiwari, the Managing Director of Biocare Life Sciences, to give us our welcoming remarks.
Dear doctors, friends in the industry, thank you to each and every one of you for being here with us today. I am very pleased to welcome those who are sharing their precious time by joining us today in this live webinar. Before we get started, I would like to congratulate the Philippine Society for Microbiology and Infectious Disease on its 50th anniversary, headed by its president, Dr. Melissa Alejandria, and the rest of the organizing committee. These past few months, you have been confined in your residences, practicing physical distancing, and adhering to all health guidelines brought about by community quarantine. Despite these measures, you continue to maneuver, working from home at the same time, attending to the needs of your patients. Mahatma Gandhi once said that the best way to find yourself is in the service of others. And that's what we strive to uphold in Biocare Life Sciences. We are a Philippines-based pharmaceutical company with a strong vision for the future in the generic pharmaceuticals, having primary interest in the importation and distribution of finished formulation, development and supplies. Emphasizing on quality technology, we carry product from reputed pharmaceuticals manufacturers around the world, whose manufacturing facilities are approved by US FDA, MHRA UK, TG Australia, and other stringent regulatory bodies. We all are facing this pandemic together, and in the fight against COVID-19 treatment, Biocare is honored to bring three game-changer products for the COVID-19 management. First, Biocare launched Remdesivir in the Philippines, which is the first generic Remdesivir in the world, manufactured by our partner Beximco Pharmaceutical from Bangladesh. And we also launched two Gillette licensed Remdesivir from Ava Pharma Egypt and Jubilant Generics India. Second, Biocare launched the first generic Favipiravir 200 mg, 400 mg and 800 mg tablet in the Philippines for mild to moderate COVID-19 treatment. Third, Biocare launched interferon beta 1 alpha in the country, which is a potential game changer for the COVID-19 management. Biocare Life Sciences continues to be in the forefront of delivering medical updates, especially at this time of pandemic. Today's forum will give us an overview and update on the role of moxifloxacin in the clinical practice and in the field of pulmonary and infectious disease. Again, we thank you doctors for accepting our invitation to attend this live webinar. Thank you.
Thank you very much, Mr. Tiwari. Now, I am very privileged to introduce our keynote speaker for this afternoon. Our keynote speaker is Dr. K. Prashant Kumar. May we have the slides to introduce Doctor? So, Doctor Dr. Prashant Kumar is a graduate of medicine at Dr. NTR University of Health Sciences in Andhra Pradesh, India. He completed his tuberculosis and respiratory disease medicine at JJM Medical Center, also in India, Bangalore, and currently he is an associate professor uh, at the, I'm sorry, I cannot read this properly, Mila Radi Institute of Medical Sciences in Hyderabad, India. Ladies and gentlemen, let's give a virtual round of applause to Dr. K. Prashant Kumar.
We are going to discuss about the moxifloxacin multidrug resistant TB. The multidrug resistant, a global threat. It's a latent tuberculosis infection, a state of persistent immune response to like stimulus like Mycobacterium tuberculosis antigens with no evidence of clinically manifest active tuberculosis. And the multidrug resistant strains of Mycobacterium tuberculosis resistant to the both isoniazid and rifampicin. And multidrug resistant tuberculosis, like how much global threat is, it's almost in 2017, MDR tuberculosis contributed as a 14% of tuberculosis deaths globally. The MDR responsible for approximately a quarter of all deaths caused by antimicrobial resistant infections. And need for the newer agents for multidrug resistant tuberculosis, the drug repurposing. That's since the turn of the millennium, there has been increasing the interest in the addressing the challenges of anti-tubercular treatment. The focus on the repurposing existing antibiotics that also have activity against TB. The development of novel compounds with effective activity against TB. So moxifloxacin is the example of this process. The role of moxifloxacin in the TB therapy. The recommended regimen for MDR TB includes fluoroquinolone and the second line injectables like amikacin, capreomycin, or kanamycin. The fluoroquinolone moxifloxacin has been shown to have a potent activity against Mycobacterium tuberculosis in vitro. In addition, moxifloxacin seems useful in case of resistance against early generation fluoroquinolones. So moxifloxacin also an important role in the management of patients who are unable to tolerate a standard regimen or they have multi-drug resistance. So repurposing moxifloxacin, advantage of repurposing an existing antibiotic is important fluoroquinolone for the treatment of a wide range of infections, including community acquired pneumonia, has a good safety record and pharmacokinetic parameters ideal for daily dosing. So early phase development of moxifloxacin back generally in animal studies, bactericidal in vivo. The early phase clinical studies of moxifloxacin mainly reveals that highly bactericidal and potent. And the phase 3 studies for treatment shortening. So because of in 2014, 3 trials were reported that related to treatment shortening based on the substitution of a fluoroquinolone. The evidence of moxifloxacin in MDR TB. So the first trial, like in one of the trial is long-term moxifloxacin in complicated tuberculosis patients with adverse reactions or resistance to first-line drugs. So the Lugi Rufo Kodakasa, this article tests the safety and the tolerability of a long-term moxifloxacin in resistant tuberculosis patients and patients with intolerance to first-line anti-tubercular drugs. So if you see the anti-tubercular drugs used in combination with the moxifloxacin in the TB patients are so generally it's ethambutol and the pyrazinamide. The next level is ethionamide and the isoniazid. In some case like clarithromycin and the amikacin. So you can see the main adverse events reported by patients treated with the moxifloxacin compared to the other therapies. The most common symptoms, the moxifloxacin gastrointestinal disorders. The next is the general disorders like asthenia, edema, pain, fever, anorexia. The next level is nervous system disorders. So conclusion of the study, although the larger studies are necessary to define more clearly the role of moxifloxacin in the treatment of MDR and the complicated TB cases, the result of this study suggests that long-term use of this drug is safe. Most of the adverse effects are reported being be mild and the reversible. So the next study is evolution of moxifloxacin for the treatment of tuberculosis in the 3 years of experience. So in this case, there is 89 patients were treated with a median dose of 6.9 milligrams per kg moxifloxacin once daily for a median period of 74 days. This study to aim to evaluate the pharmacokinetic and pharmacodynamic parameters, drug to drug interactions, and the safety tolerability of moxifloxacin in the treatment retrospectively in order to assess if optimal therapy has been given. So you can see here the so that area under curve and the adverse effects of the moxifloxacin in treatment. You can see hepatic enzymes in the functions, renal function. During the treatment also there is no much change in the hepatic enzyme levels and the renal function levels. The conclusion of study, the moxifloxacin treatment was well tolerated in 89 patients receiving a dose of 400 milligrams once daily. So that means median dose of median dose of 6.7 milligrams per kg for a duration of a 74 days. So evolution of a bond like area under curve and the MIC ratio is needed to develop the optimal dosing schedule to treat TB patients and prevent the resistance. So the another study, Lancet London, England, the treatment correlates of successful outcomes in pulmonary drug resistant tuberculosis in individual patient data meta-analysis. The study compared with the association of each drug with failure or relapse versus treatment success. The treatment success was positively associated with the uses of linezolid, moxifloxacin, levofloxacin, carbapenem, and bedaquiline clofazimine. So mortality was significantly reduced with the use of linezolid, levofloxacin, moxifloxacin, or bedaquiline. Remox trial. So Remox TB trial is the 4-month moxifloxacin based on regimens for drug sensitivity tuberculosis. A randomized placebo-controlled trial that compared two experimental regimens that substituted moxifloxacin for either isoniazid or ethambutol in the first 4 months. You can see Remox TB trial. There is a control and the isoniazid arm and ethambutol arm. In both in the two cases, they have to follow up for 12 months. So there is the time to unfavorable outcome and the time to culture negative status. You can see these data confirm the results from the phase 2b studies. The substitution of moxifloxacin for the either ethambutol or isoniazid could be the better bactericidal. In contrast, time to be unfavorable outcome was shorter in the isoniazid group than in the controller group. Rifaximin trial. In this, the high dose rifampicin with moxifloxacin for pulmonary tuberculosis. The trial with a non-inferiority design that investigated a regimen substituting moxifloxacin for isoniazid in the intensive phase and compared both the fourth and 6th-month experimental regimen against a standard HRJD regimen. In rifaximin trial also 4 months regimen, 6 months regimen, there is like moxifloxacin based rifampicin, so 900 that follow up with 4th-month regimen follow up with 15 months and the 6 months regimen is follow up with the 12 months, and there is the 15 visits culture by LJR MGIT or both by site. You can see differences from the control regimen in unfavorable outcome rates. So in the per protocol analysis, the unfavorable rate was 4.9% in this, and the 3.2% in the 6 months group, and 18.2% in the 4th month group. This means that the 6-month regimen proved a non-inferior, but non-inferiority could not be declared for the 4th month isoniazid substitution regimen. So WHO treatment guidelines for drug resistant tuberculosis. So medicines recommended for treatment of rifampicin resistant and multi-drug resistant TB. There is a group A, group B, group C, group D, and the group D is add-on agents, and the group A is fluoroquinolones. In this, levo, moxifloxacin, gatifloxacin. Second line injectable agents are amikacin, capromycin, kanamycin, and the other core second line agents are ethionamide, prothionamide, and cycloserine and terazidone and the linezolid clofazimine. Add-on agents again is D1, D2, D3. D1, D2, D3. D1 is pyrazinamide, ethambutol, high-dose isoniazid. D2 is bedaquiline, delamanate. And D3 is aminosalicylic acid and imipenem, silastine, meropenem, amoxicillin, clavalate, thioestazone. See, fluoroquinolones are considered as the clinical components of MDR TB expected to assess with better outcomes. So WHO treatment guidelines draw attention to the higher bactericidal activity of the latter generation fluoroquinolones such as moxifloxacin. The, the final summary of this moxifloxacin is safe as standard regimen components. Higher bactericidal activity should be considered for use as a key component of the treatment of MDR-TB and also those unable to tolerate the standard regimen. Thank you.
Thank you very much, Dr. Kumar, for that very concise but very informative lecture. At this time, I would like to introduce our panelists to give their reactions to the lecture of Dr. Kumar and probably give additional insights as to the clinical use of moxifloxacin. They will add some more answers to the question, MOXI-Why? Di ba? Yun yung topic ng ating session for this symposium. I'd like to introduce our first panelist, Dr. Evelyn Rojas. Dr. Evelyn Rojas is currently a professor, an associate professor at the UP Manila College of Public Health. She graduated from Pamantasan ng Lungsod ng Maynila College of Medicine and completed her master's degree just recently in public health at the UP College of Public Health. She is currently the president of the Philippine Hospital Infection Control Society and the current head of the Section of Infectious Diseases, Department of Medicine at Manila Medical Center. That's Dr. Evelyn Rojas. Our second panelist is Dr. Joel Santiago. Dr. Joel is a graduate of the UP College of Medicine under the Intermed program. Pareho pala po tayong Intermed program, sir. And he completed his internal medicine residency and pulmonary medicine fellowship at the UP Philippine General Hospital. Dr. Santiago is a fellow of the Philippine College of Physicians and Philippine College of Chest Physicians. He also completed his master's degree in occupational medicine at the UP College of Public Health. Currently, Dr. Santiago is an associate professor at the UP College of Medicine and is the training officer, Department of Medicine, Quirino Memorial Medical Center. Let's call in Dr. Evelyn Rojas first.
Okay, so good afternoon and thank you very much, Dr. Roman, for that kind introduction. And I would like to thank PSMID, organizers of the PSMID, and of course, Biocare for inviting me to have a reaction to Dr. Kumar. We would like to congratulate Dr. Kumar for that very comprehensive lecture about moxifloxacin. So I'll just give a background and as a sort of reaction to your lecture on the status of tuberculosis in our country. So according to the Global TB Report 2020 by the World Health Organization, our country, Philippines, belongs to the top 20 countries with the highest estimated number of TB cases and including incident multi-drug resistant tuberculosis. Among the ASEAN countries, it has the highest TB incidence, and TB actually is the 8th leading cause of mortality and morbidity among Filipinos. According to the recent National TB Prevalence Survey done last 2017, there are around 1 million Filipinos affected with tuberculosis, and of these, more than 7,000 are actually multi-drug resistant patients, multi-drug resistant TB cases. More recently, the incidence of TB in the country is said to be 599,000 with a rate of 554 per 100,000 population. And of these, 21,000 are categorized as multi-drug resistant or leaf-resistant TB. So thus, TB is still considered as a major public health concern, not only globally, but also in our country. Here in the Philippines, the National Tuberculosis Program, or the NTP of the Department of Health, takes care of the implementation and ensuring that the TB management in the country is in place. However, due to the recent condition, it faced a lot of challenges. So there are a lot of key challenges in the implementation of National TB program, particularly in this time. And one of these key challenges is said to be the low treatment success rate, with only 83% success rate for drug susceptible cases, and all the more lower among drug resistant TB with 58% success rate. Thus, one of the strategies mentioned in the National TB program is to increase the proportion of patients on home and community-based care. And they mentioned that the program is starting to have this rollout of shorter all-oral regimens, as mentioned by Dr. Kumar a while ago, and implement novel tools, including new anti-TB drugs. So you've mentioned this, I grabbed this in your presentation, Dr. Kumar, that fluoroquinolones, particularly moxifloxacin under the fluoroquinolone family, is included in the medicines that are said to be offered for multi-drug TB treatment, okay? Intended to guide the design of conventional regimens, as I've said, for shorter regimens lasting 9 to 12 months. So as you've mentioned a while ago, Dr. Kumar, it's intended for as an option for multi-drug resistant TB treatment, and also as an alternative for the standard anti-TB treatment whenever the patient develop adverse drug reaction, for example. I just want to share with everyone that I'm with the College of Public Health, and for the past few weeks, we've launched this online platform about TB Academy updates on the clinical management of TB and MDR TB patients, in collaboration with the Department of Health and the International Union for TB, International Union Against TB and Lung Disease, or the Union. And we have a weekly session, live session, with the different officers or chairs of the TB Medical Advisory Consilium all over the country. And we've discussed the latest management of MDR-TB, and it's included the rollout of the shorter all-oral regimen, okay, for these MDR-TB patients. So I think this is a very relevant information for all of us, particularly in the management of TB, both susceptible and drug-resistant tuberculosis. So in summary, as we are in the pandemic now, so we are in COVID-19, and our health systems have given most of their attention to COVID-19. So some health programs, including the TB control programs, face challenges in its continuous and successful implementation. However, despite of the pandemic, we should always remember that proper management of TB patients should not be forgotten, as we don't want to have an upsurge of TB cases, both susceptible and drug resistant, in the coming years. And because of the magnitude of the cases and its impact, okay, should still be included in the priority programs in our country. So these are my references, and I think this is my last slide. Thank you, Dr. Roman.
Thank you, Dr. Evelyn. Dr. Santiago, you have the floor. Sir, you're muted.
Okay, good afternoon. And first of all, I'd like to congratulate the organizers of the PSMID convention. And thank you for having me as one of the reactors. So for my part, I would focus on community-acquired pneumonia and the possible impact of the use of fluoroquinolones, and this would include moxifloxacin in TB endemic countries. So first of all, I'm showing the slide of different studies done previously using and comparing moxifloxacin against other treatments or antibiotic treatments and combinations for community-acquired pneumonia. And as you can see here, In most studies, it had been shown that moxifloxacin was superior, if not at least at par, with other treatment regimens. But uh, your moxifloxacin, your fluoroquinolones would still be part of the treatment options for community-acquired pneumonia. But my focus, or what I would want to discuss, would be the use of fluoroquinolones in treating community-acquired pneumonia in areas where TB is endemic, and that would include the Philippines. First of all, if you would want to look at the prevalence or incidence of TB, which is presenting as community-acquired pneumonia, it varies. So in Taiwan, for example, 1 to 3% was the prevalence rate, and in India, it had been found to be higher, and it was up to 70%, where patients who had initially been suspected to have community-acquired pneumonia later turned out to also have tuberculosis, or actually had tuberculosis. And most of those patients with TB who had presented as community-acquired pneumonia were of advanced age, so more than 65 years old, and had various comorbidities, which could be expected. Now, we also have our own local data. So this is an older study done in the Philippines, where they looked at the different organisms that was found to have caused community-acquired pneumonia. And as you can see here, more than 7%, or almost 8% of the cases that had been studied in lung center had turned out to be caused by Mycobacterium tuberculosis. So that means that a significant number of our pneumonia cases actually may be due to Mycobacterium tuberculosis. And this is even more true, or particularly true, in patients who have been who are HIV infected, where despite being smear negative, almost at least a third of them would turn out to be to have pulmonary tuberculosis, and this is especially true in those patients who had low CD4 counts. So with that, or considering that, the other thing that we would want to ask is, giving your fluoroquinolones, would it have an impact in the development of culture or smear negative tuberculosis? And from studies done previously, which looked at the different risk factors for culture negative tuberculosis, it has been found that up to 23% of those who were later diagnosed to have tuberculosis had been given fluoroquinolones. But from their data, or from the results of their study, prior fluoroquinolone exposure was not associated with culture negative tuberculosis. So there was no statistical significance in their study. And really, what had been proposed was that uh, delays in the suspicion or treatment and diagnosis of tuberculosis among hospitalized patients are common even without exposure to fluoroquinolone. So a lot of times patients would have been treated for bacterial pneumonia, and there was no initial consideration of tuberculosis. But in some patients, especially those with significant risk factors or are more older, it can turn out that the findings, or the X-ray infiltrates, and the clinical findings of the patient may actually be due to tuberculosis. This is another study where they looked at culture confirmed TB patients in the US who were surveyed from January 2002 to 2006. And it was found that some of the patients with fluoroquinolone resistant isolates were compared with those with susceptible isolates. And from the more or less 640 patients, what had been found to be significant is that if the patient had been treated with fluoroquinolones for more than 10 days before the diagnosis of TB, it can be associated with resistant mycobacterium or fluoroquinolone resistant mycobacteria. But otherwise, if treatment was less than 10 days, or if it was just one time that the patient had been treated with fluoroquinolones, the risk of uh, fluoroquinolone resistant TB would be significantly lower. So this just highlights the data from that study from Tennessee. Again, that more than 10 days of fluoroquinolone exposure can be associated with fluoroquinolone-resistant tuberculosis, and that age, sex, race, HIV status, and the site of disease were not associated with that same risk. There was no trend in higher fluoroquinolone resistance over time, and that aside from the number of days that patients were exposed to fluoroquinolones, those receiving more than one course of fluoroquinolones were the ones who had a more likely risk of developing fluoroquinolone-resistant tuberculosis. So more or less, that would be what I would want to emphasize, that fluoroquinolone use for patients with respiratory tract infections can still be appropriate even in TB endemic regions. Prolonged courses of fluoroquinolones may be associated with the emergence of resistance, and delays in diagnosis of TB even without the use of fluoroquinolones unfortunately is still common. So we should not blame giving fluoroquinolones in the development of or in the delays in diagnosis of TB in patients who also present with pneumonia, and that the evidence to suggest fluoroquinolones delayed the diagnosis of tuberculosis is not convincing at this point, and that if a patient presents with a protracted respiratory tract infection, especially if they're presenting with cough, fever, weight loss, and with likely cavitary lung lesions, then you should suspect tuberculosis. And do not try to use antibiotics, especially your fluoroquinolones, without excluding TB first. So, thank you.
Thank you very much, Dr. Evelyn and Dr. Santiago. At this point, I'd like to call Dr. Kumar to join us in the panel. We have a few minutes to answer some questions, but I am not seeing any questions in the chat box. But let me just throw in the first question to Dr. Kumar. Dr. Kumar, from the studies that you have presented, do you have any reports on the most common adverse drug reactions experienced by patients on prolonged use of moxifloxacin?
Yeah, generally, most common causes are gastrointestinal. Even though compared to gastrointestinal, there are few cases are like pedal edema, like pain, like they will complain to have fever. But this is not over the 5 days course. It is over the long term course, like more than 10 days. Then the problem will be started like so. The symptoms, like generalized symptoms, will be more compared to gastrointestinal symptoms. But nervous disorder symptoms are very less compared to gastrointestinal symptoms.
To anyone in, thank you, doctor. To anyone in the panel, any reports of tendon rupture like we see in other quinolones? Yeah, personally, I have not
So
experienced that. Maybe Dr. Joel?
yeah, so far I've been practicing for 10, 20 years, and so far I have not seen any uh, uh, cases of tendon rupture due to fluoroquinolones.
Yeah, Dr. Joel, that's good to hear because incidentally, I'm on moxifloxacin right now for dental alveolar abscess, but hopefully I won't be experiencing tendon rupture in the near future. Yeah. Mm-mm. So, do you have any other questions? Maybe I can ask Dr. Eva, any other indications where we can use moxifloxacin in clinical practice? Oo.
So as we all know, we treat moxifloxacin for our as an antibacterial for our infection, whether pulmonary or skin and soft tissue. But I think the more recent or the biggest addition is that it can be an additional drug for TB. I want to ask also Dr. Kumar or maybe Dr. Joel, am I allowed to do that, to ask them? I haven't tried offering moxifloxacin, Dr. Joel, for uh, drug susceptible TB or even for drug resistant tuberculosis. So I have no much experience because Dr. Kumar, our practice here in the Philippines is that for MDR-TB, we usually refer the patients to the MDR centers, treatment centers. So,
Dr. Kumar?
Probably I can answer first. Yeah. I think he's still muted. Eva, so far, I have, theoretically, we can give fluoroquinolones for patients with drug susceptible TB, but as much as possible, we should refrain from doing so because historically, it was ofloxacin, another quinolone, which was, and ciprofloxacin, which was pushing the development of drug resistance to TB before. But we now have levofloxacin and your moxifloxacin, which are better and which would have better susceptibility for TB, but still we would not recommend giving it for treatment of drug susceptible TB, not unless you have adverse drug reactions to your first
Yeah.
line drugs. Then you can give that as an additional treatment. But as much as possible, again, I try not to give it as an additional treatment. And if the patient turns out to have drug resistant TB, then I refer to the PMDT for the full regimen. So I try not to give it as much as possible.
Yeah, I think yun talaga yung most common scenario kung kailan na-use yung moxifloxacin as a treatment for drug-susceptible tuberculosis. Patients started on quadruple anti-TB meds, develop rash or hepatitis from your pyrazinamide, and then moxifloxacin is used as a fourth drug during the intensive phase. Is that similar to what's happening, Dr. Kumar, in your area of practice?
Yes, yes, same. Like whenever the patients are experienced like rashes and the jaundice, like any elevation of liver enzymes, there we will go for the maxifloxin, and whenever the levels will become normal, then immediately we'll shift to the HRJD theme only. Like we are immediately like whenever is a possible. So there, if there is no possible that the condition is like the patient symptoms are more like thick walled cavity, like he's expected, like he's coughing more. That kind of times, instead of stopping ATT complete, then we'll go for the modified regimen. There we'll start the moxifloxin.
Thank you, Dr. Kumar. And thank you to our panelists. At this time, I would like to call Mr. Ronald Z. Palacio, the Business Unit Head of Biocare Life Sciences Incorporated. Ronald?
Thank you, Dr. Raman. So it was truly a very enriching afternoon learning from our expert and esteemed speakers. On behalf of Biocare Life Sciences Incorporated, I would like to thank you, our doctors and healthcare partners, for attending this webinar. To the Philippine Society for Microbiology and Infectious Diseases, thank you and congratulations for organizing this event. Once again, we would like to express our appreciation to Dr. Kumar for sharing with us his experience, expertise, and know-hows, and to our expert panelists, Dr. Evelyn Rojas, Dr. Joel Santiago, as well as to our moderator, Dr. Arthur Desiroman, our gratitude for joining us this afternoon. Once again, thank you, Doctor, for spending your time with us. Stay safe and good day.
Meron pa po bang last word si Dr. Joel, si Dr. Kumar, or Dr. Evelyn Rojas? None?
Ako,
Yes.
I just want to add here that hindi ko na-add kanina, no? So moxifloxacin in the setting of treatment for TB somehow surfaced because of the release of the rollout of the shorter all-oral regimen for multi-drug resistant tuberculosis, particularly in this time of pandemic wherein we lessen the face-to-face contact. So one of the strategies of the National TB program is to have this all-oral short regimen and shy away from the injectable drugs against multi-drug resistant TB. That's just my additional point. Thank you, Dr. Roman.
Thank you. Thank you very much, Dr. Kumar, Dr. Rojas, and Dr. Santiago. On behalf of the board of the Philippine Society for Microbiology and Infectious Diseases, I would like to thank Biocare Life Sciences for partnering with us in mounting the 42nd annual convention. We felt that the scientific lessons we will impart in this convention needs to be communicated now more than ever ngayong nasa pandemic tayo. And your partnership in this endeavor has helped to make this happen. We shall be sending certificates of appreciation to all our speakers and panelists. So make sure there'll be someone to receive the special package, the special certificate of appreciation. I'd like to thank all the attendees to this afternoon's lecture, and we look forward to seeing you again in the main scientific sessions. There are more scientific sessions to follow later this afternoon and this evening. Please don't forget to exit this Zoom webinar room and click on the evening session Zoom links on the convention website proper. Again, maraming salamat po. Ingat po tayong lahat.
Thank you.